Hello and welcome everyone. This is week 8 and lecture number 40. This is the final lecture in the knee injury rehabilitation course. In today's lecture, we will see the long term joint preservation and osteoarthritis prevention strategies. The objectives for today's lecture are to understand why knee ligament injuries increase the risk of early osteoarthritis, to recognize modifiable and non-modifiable risk factors for joint degeneration, to learn evidence-based strategies for joint preservation post-injury. We will also explore rehabilitation and lifestyle modifications that reduce osteoarthritis risk. We will apply long-term monitoring and preventive care in both elite and recreational athletes. So, without further ado, let's begin. It is said that every ligament injury leaves a long shadow. Even when athletes return to sport, the knee still remains vulnerable to injury. Ignoring joint health initially will lead to arthritis in the later stages of life. Protecting cartilage is just as important as restoring function of the knee. Poor cartilage health may lead to poor prognosis. Simple choices in training and rehab have lifelong consequences. This lecture focuses on preserving knees for decades beyond sport. Knee ligament injuries substantially increase long term risk of osteoarthritis, with studies showing that nearly half of the patients with ACL or meniscus injuries develop radiographic osteoarthritis changes within 10 to 15 years of trauma. The risk is even higher, often exceeding 60%, when both the ACL and meniscus are injured together. Importantly, the development of osteoarthritis is not prevented by surgical reconstruction alone, as altered joint biomechanics and biological changes persist even after a technically successful procedure. Compared with age-matched controls, athletes with prior ligament injuries have a 3 to 6 times higher risk of developing osteoarthritis. For those returning to high impact sports, the risk accelerates further as repetitive loading magnifies cartilage damage. These findings emphasize that osteoarthritis is not a distant complication, but an expected trajectory for many, unless long term preventive strategies are adopted. Thus, our challenge in sports medicine is not merely to help athletes return to play, but to preserve joint health throughout their career and beyond. The pathophysiology of post traumatic osteoarthritis begins with abnormal joint loading created by ligament injury. For example, ACL deficiency allows anterior tibial translation, while PCL deficiency creates a posterior sag of the tibia, both altering the tibiofemoral contact pressures. While meniscus tissue is damaged or excised, its shock absorbing function is compromised, concentrating compressive forces on the articular cartilage. At the same time, biochemical changes occur within the cartilage, with early matrix degeneration visible on advanced imaging such as T2 weighted MRIs. These changes are compounded by persistent synovial inflammation, which maintains a catabolic intra-articular environment. Episodes of instability further accelerate cartilage breakdown, while altered gait mechanics and persistent muscle weakness perpetuate abnormal loading. The disease process, therefore, evolves from both mechanical and biological pathways, making osteoarthritis not simply a late complication but a process that begins soon after injury. Recognizing these mechanisms is critical as it highlights the need for early, targeted intervention to restore stability and minimize damaging loads. Certain risk factors for post traumatic osteoarthritis cannot be altered but strongly influence prognosis. Age is a key determinant, as older athletes demonstrate reduced cartilage healing potential and accelerated degenerative change. Sex differences are also recognized, with women showing higher rates of osteoarthritis after ligament injuries. Genetic predisposition plays an additional role, as some individuals are biologically more prone to cartilage breakdown. The severity of the initial trauma is another major factor. Multi-ligament injuries or meniscal root tears carry particularly poor long-term outcomes. Surgical details such as graft choice, tunnel placement, and whether a meniscus was resected or repaired further modify osteoarthritis risk. The extent of articular cartilage injury at the time of surgery also influences prognosis. While these factors cannot be changed, they allow us to identify patients who are at higher risk and which patients therefore require closer monitoring and more aggressive preventive strategies. This recognition reminds us that in many cases, prevention is about controlling what we can modify while planning carefully for the risks we cannot. Modifiable risk factors represent the greatest opportunity for preserving long term knee health. Quadriceps weakness, which is nearly universal after ACL reconstruction, has been strongly linked to higher osteoarthritis incidence. Hamstring weakness compounds this by reducing dynamic posterior support, while faulty movement patterns such as dynamic valgus during landing increase compressive and shear stress on cartilage. Body mass index is another major factor. Every kilogram of excess body weight translates into 3 to 4 kilograms of extra force through the knee joint with each step. Early return to high impact sport without fulfilling objective criteria is another contributor to the injury and cartilage degeneration. Non adherence to rehabilitation programs only magnifies these problems. Fortunately, targeted strength training, neuromuscular retraining, and structured rehabilitation protocols can directly address these risks. Lifestyle modification, such as weight control and patient education, add further protective benefits. By systematically targeting modifiable factors, clinicians can meaningfully influence the long term risk of osteoarthritis after ligament injury. Rehabilitation plays a central role not just in returning athletes to sport, but in protecting their joints for the long term. The early goal of regaining full knee extension is crucial, as failure leads to abnormal gait mechanics and persistent overload of cartilage. Quadriceps and hip strengthening restore dynamic stability, while neuromuscular training ensures controlled alignment during demanding tasks like landing and cutting. Proprioceptive and balance exercises reduce the risk of secondary injury, which is itself a major contributor to early osteoarthritis. Importantly, rehabilitation must emphasize movement retraining, correcting harmful patterns that otherwise persist into sport and daily life. Research shows that structured, progressive rehabilitation significantly reduces the long term incidence of osteoarthritis after ACL injury. However, these protective effects are only realized if athletes remain compliant beyond the initial months. This underscores that rehabilitation is not just a temporary treatment, but a lifelong strategy to protect the knee joint. Effective strengthening and conditioning strategies are essential for joint preservation. Quadriceps strengthening is especially important because strong quadriceps absorb load and protect cartilage from repetitive impact. Hamstring strength balances anterior tibial forces, providing functional support to the ACL ligament. Hip and core strengthening reduce valgus forces which are otherwise transmitted to the knee during athletic tasks. Closed chain strengthening is preferred in early rehab phases because it is safer and mimics real life biomechanics. Eccentric exercises add resilience by enhancing tendon and muscle function under higher loads. Later, functional strengthening reproduces sport specific patterns, improving transfer to competition. Conditioning strategies maintain cardiovascular and muscular endurance, preventing detraining during rehabilitation. To minimize re injury, strength symmetry is a must, with at least 90% limb symmetry required before progression to advanced tasks. Importantly, conditioning and strengthening cannot stop at return to play. They must continue throughout the athlete's career to maintain joint protection. The exercises mentioned become part of an athlete or individual's lifestyle. Load management is a cornerstone of long term joint preservation. Excessive or unplanned joint load accelerates degeneration in previously injured knees. Activities such as long distance running or repeated high impact jumping must be carefully monitored, particularly in those with combined ligament and meniscus injuries. Cross training through swimming, cycling, or pool running all allows athletes to maintain cardiovascular conditioning with reduced joint stress. Periodization frameworks help distribute workloads, ensuring a balance between stress and recovery. Athletes must avoid sudden spikes in training load, which often precipitate flare ups or re injury. External factors such as footwear and playing surfaces also influence joint loads and should be optimized. In some cases, especially for recreational athletes, sport modification may be necessary to balance enjoyment with long term joint health. Ultimately, load management is most effective when individualized and guided by both medical staff and coaches. Athlete education is central, as informed athletes are more likely to adopt safe training practices consistently. Lifestyle modification represents a powerful but often underutilized tool in joint preservation. Weight management is the most important preventive factor as excess body mass directly increases joint loads and accelerates degeneration changes. Even modest weight loss significantly reduces compressive forces with each step. Nutrition plays a role as well, with anti-inflammatory diets such as diets rich in omega-3 fatty acids and antioxidants support cartilage metabolism. Adequate protein intake is needed to maintain muscle mass during rehabilitation. Sleep quality and recovery routines influence hormonal balance and tissue repair. Avoiding smoking and limiting alcohol reduce systemic inflammation that can worsen osteoarthritis risk. Long term adherence to physical activity not only builds muscle but helps maintain cartilage health. Educating athletes on these lifestyle choices empowers them to take responsibility for their joint health. For recreational athletes, especially, balancing work, daily activity, and sport is essential. Together, these preventive measures determine whether osteoarthritis progresses slowly or rapidly after ligament injury. Monitoring for early signs of joint degeneration is crucial for long term management. Clinical follow up allows for timely recognition of persistent swelling, stiffness, or instability. Advanced imaging, such as MRI, can detect early cartilage matrix changes long before radiographs show degeneration. Ultrasound may assist in identifying effusion and synovial inflammation. Functional outcome measures like the IKDC or KOOS track patient reported decline in quality of life. Objective functional testing exposes strength asymmetries or altered movement mechanics that predispose to degeneration. These assessments provide an opportunity for targeted interventions before irreversible changes occur. Monitoring must extend beyond the typical 6 to 12-month rehabilitation window, continuing for years after injury. Symptom tracking can guide load modification and prevent flare ups. Regular follow up improves compliance with preventive strategies, reassuring athletes about long term care. Ultimately, early detection provides the best chance to slow or halt the progression of post traumatic osteoarthritis. Long term joint preservation requires a multidisciplinary approach supported by emerging technologies. Orthobiologics such as platelet rich plasma and stem cell therapy show promise for cartilage health, although evidence remains mixed and largely experimental. Mechanical strategies like unloader braces and orthotics can redistribute joint forces and reduce pain in select cases. A coordinated team approach involving surgeons, physiotherapists, strength and conditioning specialists, nutritionists, psychologists, and the sports medicine physician ensures comprehensive care. Nutritionists play a central role in guiding anti inflammatory and weight control diets. Sports psychologists support adherence to long term exercise and help athletes overcome the psychological challenges of chronic joint risk. In elite athletes, team based care is standard, but for recreational athletes, cost effective and accessible strategies must be emphasized upon. Emerging technologies such as wearable sensors offer real time monitoring of joint loads, giving clinicians and athletes actionable feedback. By combining established rehabilitation methods with new interventions, long term joint preservation becomes a realistic goal. The holistic approach ensures that athletes not only return to sport but also maintain lifelong knee function. With this, we have come to the end of today's lecture. The key takeaways from today's lecture are ligament injuries accelerate osteoarthritis risk. Hence, joint preservation requires lifelong strategies. Rehabilitation, load management, and weight control are key modifiable factors. Prevention of osteoarthritis is better than the treatment of osteoarthritis to sustain healthy joint for active life. And a holistic and multidisciplinary case ensures long term outcomes and better knee prognosis. These are some of the references that I have used in the lecture today. With this, we have come to the end of the knee injury rehabilitation course. I hope after this course, you can see knee injury rehabilitation with a different perspective and in a different light. I am Major Amar Singh, and I would like to say thank you for your time and patience. Good day.